Thank you very much, Maite. First of all, I would like to say that I'm really glad to be here with you in a full room full of friends and colleagues after we've done this for a couple of years in front of our laptops. So Michael assigned me this topic, when to worry with in athletes with ventricular arrhythmia. So I will try to give some practical insights in the approach to athletes with this problem. So these are my objectives. So first of all, we'll discuss about the nature, the investigation, and the significance of ventricular premature beats in athletes. And then we will provide recommendation for managing athletes with ventricular tachycardia. And I think we would all agree that sudden cardiac death is one of the most feared complications in athletes. And although, as testified by this slide, there is a significant heterogeneity in terms of the causes of sudden death in athletes according to different cohorts, we again would agree that ventricular arrhythmias are the final common pathway that leads to out-of-hospital and cardiac arrest in most of the cases. Young, healthy individuals who do not have an underlying cardiac disease tolerate very well all the physiological changes that come with exercise, including dehydration, adrenergic surges, electrolyte imbalance, and acid-base disturbance. These changes are not well tolerated by someone who has a pathological substrate, a structural, electrical, functional, or genetic pathological substrate. So let's discuss about premature ventricular beats in athletes. So a few points. First of all, ventricular premature beats are detected on the Holter monitor in 40 to 8% of the general population. Frequent premature ventricular beats are present in 1 to 4% of the general population. There is limited data to suggest that athletes have a higher frequency of VPBs than the control population. Among athletes, most premature ventricular beats arise from the right or the left ventricular outflow tract or the left fascicle, and they are usually monomorphic. So let's start from the international criteria, the international recommendation for ECG interpretation in athletes. And we focus, of course, on premature ventricular beats. And we see that according to this recommendation, if we find at least 2 premature ventricular beats at a 12-lead ECG, we should further investigate. So this is a study that is almost 20 years ago on more than 15,000 athletes. This is an Italian experience. The mean age was 25 years old. And we see that 2.2% of athletes had at least 3 premature ventricular beats on resting ECG or palpitations. The authors divided 2 groups. The group A was more than 2,000 premature ventricular beats and at least 1 non-sustained VT. Group B, a little bit less premature ventricular beats, and Group C, less than 100 premature ventricular beats in on the 24-hour Holter. So we see that cardiac pathology was found in 26 individuals in the Group A, so the ones that had more than 2,000 premature ventricular beats during the 24 hours. The first concept is that the number of premature ventricular beats is something we need to take in account. However, in the last few years, especially, and this is studies especially from the Padova group, and here we have Professor Corrado that perhaps can join us in the discussion about that. There are a few studies that show that the pattern of premature ventricular beats is equally important in the assessment of the athlete. So in this study, 228 asymptomatic athletes, young athletes, mean age of 21, at least 6 hours of exercise per week, compared with 144 sedentary individuals. All these individuals were investigated with a 12-lead 24-hour Holter. So the first thing that the authors found was that there was no difference between controls and athletes in terms of proportion, percentage of premature ventricular beats. There was no association with degree of training, years of sports activity, endurance exercise, and cardiac dimensions on echocardiography. But what is most important and I would say interesting is that among athletes that had more than 500 premature ventricular beats per day, they found that 10 had a left bundle branch block pattern, left bundle branch block pattern of the premature ventricular beats. 8 had a right bundle branch block pattern with a wide QRS, and out of these 8, 3 had left ventricular scar, so late gadolinium enhancement, which was mid-wall subepicardia at the level of the lateral wall. So this is the pattern of the premature ventricular beats. So as said before, athletes who have this pattern have a high probability of myocardial scar. So wide right bundle branch block and superior axis. This is quite different from what we see on this slide. So these are fascicular ventricular premature beats. So again, right bundle branch block, but the QRS duration is usually less than 130 milliseconds. So this is an ECG from a 22-year-old basketball player. Does he require further investigation, even if there is only one premature ventricular beat? And the answer is yes. Wide QRS, superior axis, okay? And this is what this athlete does at the exercise tolerance test. So he starts to develop some couples, some non-sustained VT at mild exercise, and some more non-sustained VT. And what is the finding at the cardiac MRI? Left ventricular scar. You see, mid-wall subepicardial lateral scar. So I think this slide is quite important. So try to memorize this. I can stop talking and shut up after this. So this is what we should keep in consideration, take in consideration when we're assessing premature ventricular beats in athletes. So symptoms, family history, resting ECG, so abnormalities at the resting ECG, the ectopic burden, so the number of premature ventricular beats, the ectopic morphology, as we said, right bundle branch block with wide QRS, the complexity of the premature ventricular beats, and the exacerbation with exercise. And again, as we said before, the most common premature ventricular beats in athletes are usually either fascicular or coming from the right RVOT or LVOT. Instead, we have other things that should raise our suspicion of cardiopathology. Presence of right bundle branch block pattern, as we said, repetitive polymorphic premature ventricular beats, symptoms, ECG abnormalities, and imaging abnormalities. A few words about ventricular tachycardia in athletes. So first of all, we have to remember that if we have ventricular tachycardia in athletes, ventricular tachycardia is usually a marker of risk and a sign of underlying cardiac pathology. So if we see a ventricular tachycardia in an athlete, we should do 3 things: investigate, 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 rule out underlying cardiac pathology. However, said that, after we've done all our workup, there are some cases where ventricular tachycardia is not associated with structural or functional heart disease, such as, for example, fascicular tachycardia, as in this example, right bundle branch block appearance, QRS duration, as we said, less than 130 milliseconds. So in these cases, as it is emphasized by the European Society of Cardiology guidelines, our first task is to rule out structural cardiac pathology or other ECG abnormalities, family history, or patterns that may be suspicious of an underlying cardiac disease. If we exclude this, we may consider the possibility of fascicular tachycardias or tachycardias arising from the RVOT and LVOT. And these arrhythmias are particularly sensitive to either adenosine or calcium channel antagonists and to ablation. And if an athlete undergoes ablation, he or she may restart exercise even at the highest level. So these are my take-home messages. Ventricular premature beats arising from the outflow tract or the fascicles are usually benign in athletes. Premature ventricular beats require investigation if they are frequent, complex, and increase in prevalence with exercise. Premature ventricular beats should be interpreted in the context of symptoms, family history, ECG abnormalities. Idiopathic ventricular tachycardias with a structurally normal heart may be amenable to treatment and returning to competition. Thank you very much for your attention.